and welcome to feedback loop 1 of the co-design of the Murrumbidgee LHD safe space in the Wagga region. I'm Carrie, I'm one of the facilitators. This is Tina as well, who's another facilitator of this co-design process with Roses in the Ocean. Thanks, Tina. So just begin with some acknowledgements. We'd like to acknowledge and pay our respects to the original occupants and traditional custodians of all the lands we're meeting on, like in a virtual environment that's often many lands, but particularly acknowledge the Wurundjeri people of the Murrumbidgee region, and to pay our respects to elders past, present, and also their emerging leaders, and also to acknowledge any Aboriginal and Torres Strait Islander people who are participating in this co-design process, and also just to really acknowledge the enormous contributions that Indigenous people and communities are making to suicide prevention efforts all around Australia. In the context of suicide prevention, we also like to acknowledge people with lived experience, and that is particularly around with co-design, just really acknowledging the uniquely valuable expertise that experts by experience bring, as well as traditional experts in the co-design of health and social services, and particularly around alternatives to emergency departments, really getting the lived expertise of people who have experienced suicidal crisis and attempt, and what they bring to these processes. So thank you. Thanks, Tina. So just a little overview of the process so far. We've brought together people with lived experience in focus group conversations, and then they were just smaller group discussions, and then we brought them all together in the combined lived experience session, which was a half-day session online. And then also we have recently spoken to health professionals in those focus group conversations as well. So where we're up to now is this feedback loop, and the purpose of this is to provide context of the co-design process to date, to make sure we've captured what's been shared during these initial sessions, so the focus group conversations and also the lived experience session. But importantly, it's to gather broader views and experiences. So we know that only a limited amount of people can directly participate in co-design, and that's particularly the case in a virtual co-design process. It's only small numbers that are directly involved, and so it's super important that we get the broadest range of views and experiences of that broad community input as well, and that's what this feedback loop is partly about. It's also about helping people to prepare for the next stage of the co-design process, and we'll explain to you at the end how other people can participate through a survey. Thanks, Tina. So it's always, as I've said, super important to get a broad and diverse range of perspectives in co-design if we want to develop service models that are really going to meet the needs and wants of the broadest range of people in local communities. But we also realise that it's very important to get the perspectives that are relevant to the service model that's being co-designed now in the case of an alternative to ED service for people in suicidal crisis. What's very important is to get the perspectives of people who have had suicidal thoughts, have survived a suicide attempt, have cared for someone who has been suicidal and or attempted suicide, and those people who are bereaved by suicide. Thanks, Tina. So what we did in those focus conversations and then in that bigger session is we walked through the emotions and feelings experienced by someone seeking help through ED for a suicidal crisis, and explored the reasons why they felt that they felt that way and what needs they had at each stage. We also very importantly explored the experiences of people who had chosen not to go to ED for a suicidal crisis or in suicidal crisis, and also importantly for people who have chosen not to go back as a result of their experiences. We tried to map these according to what we're calling the touch points of the ED process. So so reaching out and trying to get help in the first place, or supporting someone to do so. The initial period of arriving and assessment, the waiting period, which we know can be a very important part of people's experience, the treatment, and that may be in ED, it also may be in a hospital inpatient setting, and then leaving, what it was like for people to leave. And so the following slides highlight the key points of discussion, and also it really is about providing, sort of capturing what the common themes are that have emerged, so people can see what's starting to emerge from these co-design sessions in terms of sort of the foundational ideas that are going to, the safe space co-design process, where we're really starting to look at the service model, will really be built on. And that includes things like the values and principles that the co-design, that the safe space will need to align itself to. And Tina's going to take you through these feelings, needs and ideas in a moment, but just to let you know that how we're framing them is in terms of I guess basically what are the main sort of feelings that have come out, and you'll see that it's been we've created a word cloud, but also just to really animate and give power to some of these points that are being made. There are also, we've captured some quotes from people directly. Now they're de-identified, but they really do speak to people's direct experiences in your local area. Thanks, Tina.
So as Carrie said, we spoke to people about their experiences of either trying themselves to access help through the emergency department during a suicidal crisis, or of supporting someone to access help through the emergency department. And the first thing that we spoke about in our groups was people's experiences when they were trying to find help through the emergency department. So find out what they needed to do in order to access help. And there were a number of feelings that came up in this conversation for people, but you can see there in the word cloud that some of the words are much larger, and the larger words reflect that they were feelings that more people spoke about. So they were very commonly expressed feelings. And when we were talking about people's experiences trying to find help through the emergency department, the two really strong feelings that got expressed were feeling anxious and feeling desperate. Some of the other feelings that were raised, people felt daunted, they felt shame, scared, feeling judged, invalidated, embarrassed, aggravated, and frustrated. So we asked people to help us understand why they were feeling this way, and some of the things that were said in the group. So this first comment came from somebody who went to try and find help through the emergency department, and because they weren't being helped, left. And their experience after they left was, I was brought back in by the police. I was not well enough for them to help me when I went in, but I was unwell enough for the police to get me. Another comment was made that someone was feeling quite negative about finding help through the emergency department because they said they will make me feel ashamed of what I have done. Another person said, I was worried that people would look at me and think I'm a crazy person. And another comment was that it's not just about losing control of yourself, it's about losing your job. So that experience of trying to find help involves people really being affected by broader consequences for their lives. Another person said that the reason they were having negative feelings around finding help was that by the time you got to the emergency department, you have exhausted all of the help available in the community. So then we asked people about their experiences when they arrived at the emergency department and during that initial assessment. And you can see there's a huge number of feelings that people expressed around what it was like for them during that arrival and initial assessment. Really common feelings that were expressed were feeling frustrated or frustration, angry, feeling unworthy, and feeling a sense of despair. Some of the other things that people described feeling judged, invalidated, traumatized, having sweaty palms, feeling embarrassed, feeling unseen and invisible, feeling unheard, feeling shame, confused, despair, feeling disappointed, feeling stigmatized, feeling dehumanized, unwanted, and disrespected. And another person explained, I wanted to take my life. So when we asked people about these feelings and, to help us understand why they felt that way, one person explained, once you enter that building, you lose your rights and you lose your voice. Another person said that they felt that the hospital should have been prepared for them to arrive, but instead, my psychologist and my psychiatrist sent them all the paperwork and they still made me wait 8 hours before they admitted me. Another person spoke very directly about what it felt like to be assessed in that initial assessment and said, I don't need to be compared to other people. I need to be treated like a human being. Another person talked about the fact that even though they'd gone to the emergency department for help, they said, I knew the outcome would be that I would be sent home. One person who spoke to us spoke about the perspective of a person who has been given a diagnosis of borderline personality disorder. And that person said that when you turn up for arrival and initial assessment, people judge you straight away. It's really hard to get help when you have BPD. So then we asked people about their experiences when they were waiting. And waiting can happen on a number of occasions when people try to access help through the emergency department. So we asked them what that was like. And the biggest feeling that got expressed there was that when people are waiting, they're feeling invisible. Some of the other feelings that people talked about, they felt worthless, judged, vulnerable, scared, panicked, lonely, awful, distressed, aggravated, alone, angry, detached, invalidated, fear, hopelessness, ashamed, unworthy, scared, disheartened. And one person said that when they were waiting, they had increased feelings of suicidality. So people helped us understand why they were feeling this way and explained the reasons for these feelings. And in terms of when they're waiting, a very common idea that was expressed was that other people are coming for a real emergency, so you can wait. Another person said, I felt like I was in trouble, like I was a criminal. One person described spending 5 hours waiting on the floor with a blanket over them. Another person said that when they're waiting, they get the feeling that the system pushes you aside and says, we'll get to you later. And another person explained to us, you wonder why you've come here. You would have been better staying at home. So some people who went to the emergency department for help during a suicidal crisis received treatment in a mental health unit. And we asked them about how they felt during that treatment. The big words that were raised when people were describing their feelings during treatment were feeling embarrassed, feeling unworthy, and feeling hopeless. Some of the other feelings that were spoken about, feeling imprisoned, stigmatized, distressed, trapped, dazed, anxious, feeling shame, ignored, unworthy, feeling abused and anger, feeling pain, feeling inferior, pointlessness, frustration, feeling teary, feeling guilt, tense, judged, feeling confused, feeling physically ill, patronised, agitated, and invisible. So we asked people to explain why they felt that way during treatment. And one person said, the staff in the fishbowl don't answer your questions. There were also a lot of comments about the focus of treatment. And one person explained, the first resort is what drug can I give this person to take away the symptoms? Another person spoke about not really getting time to speak with health professionals. And they said that the psychiatrists see 100 people and they only have 5 minutes for you and ask how your medication was going. And a lot of the feelings that people had were associated with the fact that they felt that there was a focus on medication and that there were other things that they needed to have a focus on. Another person described feeling guilty. They said, I felt guilty about taking up people's time and resources. And another person commented, you were patronised and treated as though you were simple and stupid. So then we asked people about how they felt when they were leaving. So that might have been leaving directly from the emergency department, or it might have been leaving after treatment. And the really strong feelings that came up in those conversations were that when people are leaving, they feel scared, they feel angry, and they feel embarrassed. Some of the other feelings that people had were described as feeling dark, feeling frustrated and confused and anxious. People felt guilty, they felt hopeless and felt awful. Some people felt like they were in crisis and felt very isolated and disillusioned and disappointed. So when people explained these feelings and the reasons for these feelings, some of the comments that were made in the groups, one person described the day that they left hospital. That day was one of my darkest days I got to. And if I hadn't got a call from a friend, I wouldn't be here today. Another person said that in terms of the reason they left and their feelings of frustration, I got sick of waiting and I left, so they sent the cops after me. Another person said that when they left hospital, they said, I wanted to hurt myself again, but I felt too guilty to do that. A lot of people spoke about how they felt in terms of feeling very disillusioned. And a fairly representative comment was, it was going to take a week before they were going to see me at community mental health. So people spoke about not really having a lot available for their support once they were leaving. One person spoke about the impact on their family. They said that when they left, my sister had to agree to be on suicide watch for me, which I felt was a bit much to expect of her. So after we'd finished talking about the process, we had a chat with people who either haven't accessed the emergency department during a suicidal crisis or have done it in the past but would never do it again, would make that decision not to access help that way. And we asked them for their reasons for that. And the reasons they gave for not wanting to access help through the emergency department was, you're stuck between a rock and a hard place and you can't seem to find the answers. Another person explained, I didn't go to the emergency department because of my previous experiences. Again, another person commented that there is stigma in hospital. They don't think it's a real illness. They would rather treat someone with a broken leg. Some people felt there's not a lot of options for help. And they said there's really no option other than your GP. They wouldn't consider the emergency department a valid option anymore. Another person said that they wouldn't seek help that way because the minute he stepped into a public hospital, it became very public and he would lose his job. Another person commented that I get pissed off. So many emergency services people suicide and they do nothing about it. So that was a comment from a person who was experiencing a suicidal crisis and worked within emergency services. And they were commenting not just on the response of the emergency department, but also the response within those services, the emergency services. And another person commented that they wouldn't go to the emergency department because the help is not there and you have to get to a crisis point and be brought in by the police or an ambulance. So these conversations we had about people's experiences and their feelings were actually really important because we were able to use them as a basis to look at what people's needs might be when they're experiencing a suicidal crisis. And we identified a number of needs for people in Wagga, and one type of needs is practical and physical needs. So the need for distracting activities came up regularly in the conversation, that people, when they're feeling distressed, can't be left by themselves with nothing to look at other than a bare wall. And the need, very related to that, the need for stimulation. So people don't want overstimulation, but they just feel like they need some kind of stimulation. People have a need for water and refreshments, for a change of clothes, for physical comfort and warmth, and for a bright and warm environment. They feel the need for separate private spaces with access to a quiet room. So that was really a response to the very public nature of seeking help through the emergency department. And there was really a feel that there's a need for people to be able to, when they are waiting and accessing help, to be able to do that in privacy. People spoke about the need to be able to have a support person or an advocate present, rather than being required to go through this process of seeking help by themselves. And also to have a welcoming environment for safety and security, and to have the sense of being in a helping and welcoming environment rather than that prison-like feeling. So that's very much a response to those feelings of being trapped and those feelings of not having options. And the people with lived experience in Wagga were able to identify a large number of needs that we would describe as connection needs. So they described the need for connection, attention, and meaningful interaction, for someone to open up to and talk with, for respect, compassion, trust, and empathy, for a compassionate and validating response. People talked about the need to recognise strength and capacity, and for a person-centred approach with trauma-informed care. People feel the need to be listened to without judgment, and to have timely access to support rather than waiting for long periods. They would like understanding staff who have the skills and the knowledge to assess and help, and staff who are knowledgeable in mental and emotional health and the various stressors that lead to crisis. So there was very much a theme in the conversation about the need for people that have the required knowledge to understand what they're going through. People identified the need for follow-up and a clear pathway forward. So particularly once people had finished that process of seeking and accessing support. There was a lot said about the need for cultural safety and for respect for Aboriginal and Torres Strait Islander communities. And that Wagga in particular spoke at quite a lot of length about cultural needs and the need to meet the diverse needs within the community. There was also conversation around the need for various treatment options and therapies available, and to be able to to be able to respond to frequent attenders rather than turning people away because they've presented for help frequently in the past. So the ability to respond to sexually and gender diverse communities, to be monitored in a safe way, and also for lived experience involvement. In terms of information, a few needs were identified there. So people feel they need a clear explanation of what to expect with medication. Also a need for communication about what's going on and the process, the need for additional resources, to be informed about treatment options, and to be able to make informed choice about treatment decisions. And just some other general needs that were raised in our conversation. People spoke about the need for fairness and equality, for understanding and acknowledgement, for decency and privacy, to be treated with dignity and respect, to uphold human rights, to work with people who are hostile and guarded, to engage and collaborate in care. So I guess an openness to being able to engage with and collaborate with all people. Also a need to be treated ethically and morally, and the need for gender-informed practice.
Thanks, Tina. I hope that people can see already just the incredibly rich contributions that people, the lived experience participants, made right from the beginning in those focused conversations, really bringing a real depth of insight about their experiences. And then in this second part that we're going to go through, you'll see that those unmet needs that they had identified and that led them to those sort of feelings and emotions around their experiences. Now they've really brought immediately these really amazing ideas about what an actual local safe space would look like in order to meet some of those needs. So we'll just take you through now the values and principles, firstly, that were started to be agreed upon. So we know it's important that values and principles are identified as part of the co-design process, because they can therefore guide the local safe space, particularly when there are tricky situations or sort of ethical dilemmas that arise inevitably in social services. What are the guiding principles? What are the values that underlie this innovative new way of supporting people in suicidal crisis? And people with lived experience came up with a whole bunch of values, but the ones that have been broadly agreed upon are respect, holistic care, compassion, culturally competent, confidentiality, collaborative, as Tina was talking about, trauma-informed, and also co-design. So that idea that people were saying co-design process doesn't stop with this process of drafting a service model, but is really seeded into the model itself and for the life of the service. Thanks, Tina. And these were just some of the other values that were raised. So comfort, understanding, empathy, communication, listening, warmth, appreciation, choice, non-judgmental, dynamic, privacy, developmentally appropriate, adaptable, social justice, acknowledgement, human decency, non-linear, dignity, continuous improvement, education, healing and helping focused, growth, authenticity, customer service, respect for diversity and trust. And while they aren't necessarily all strictly values, that you can see now already that there is really this is about articulating the general approach to supporting people. And some additional comments provided were around that and this was a really important perspective that someone brought, that values sometimes are just perceived as rhetoric. Interpretation and application of values is critical. So it's all wonderful to have these nice shiny values sitting on a shelf somewhere in principle, but it's about the application of them in practice. That's what's important, and to also acknowledge that values will look different to different people. Thanks, Tina. And these were the draft principles. So there's going to be a bit more wordsmithing around this that will encourage people with lived experience to do. So these aren't the final form, but people just I thought really immediately drew out some really important draft principles here. So we acknowledge everyone has different experiences. We are committed to embodying our values and practicing them in our approach. So you can see that reflects what I was saying before, the commentary around values being about something that happens in practice, not just in principle. Our commitment is for people to leave better than when they arrived. We offer holistic human interaction without deadlines and timeframes. We offer true person-centered care from people who have their own lived experience, where people become centre stage in their recovery, and we are constantly learning and improving. Thanks, Tina. So here's where people started to come up with some just really fantastic ideas about what does that local safe space look like. So we're starting to see the sort of the model take shape a little bit here, and really people thinking about what were those needs that they identified that weren't being met in their own experiences of either seeking help through ED, suicidal crisis, or supporting someone to do so. So the physical environment, people, there was broad agreement around this, that there needs to be opportunities for distraction, for example, magazine, TV, arts and crafts area, food and drinks available, so a kitchenette perhaps with tea and coffee and food, 24-hour cafe, a food bank with options to take home pre-prepared meals, a homely feel with comforts like a proper bed, couches, bean bags and weighted blankets. So there was this emphasis on the idea of people needing sensory-based activities and supports, plants, a bathroom with a bath. So people were talking about not wanting those, those very sterile bathrooms you get in hospitals, a sensory room or a garden with outdoor space. That idea of is something that engages all 5 senses. So a recognition of the holistic nature of people's need for support. Warm lighting, calming tones and colour in terms of the paint even on the wall, art on the walls, a blackboard for people to post questions, including prompts for what people might want to ask or say. So that was really about, there was conversation around the fact that people do not want to be overwhelmed by information or the need to have to tell their story, that might be a sort of a gentler, more indirect way for people to be communicating with staff. Also separate private rooms and separate areas for those both needing stimulation, but also like a lower level of stimulation in their interactions. Calming music and noise cancelling earphones that are available, a phone charging station. So recognising those very basic practical needs that people have that aren't being met in the current system. Area for children to be safe, like a nursery or child minding facility. First aid medical area, a smoking area as well, recognising that a lot of people in crisis and distress need somewhere to smoke, and also a clothing bin was another suggestion. Thanks, Tina. We then had a look at location and accessibility, and people really did emphasise the need for it to be accessible to public transport or to walk, recognising that transport or accessibility is quite a fundamental barrier to access in services. That there's a private and safe entrance, which is wheelchair accessible, that it's out of sight of ED in the inpatient ward. So people telling us, those people that had shared those quite negative experiences, that it would be important for people to feel that there was a real separation, and also for people that may have had very unhelpful or traumatic experiences with the current system and services, that they would want to have a safe space that was out of sight of those services. And also an access to interpreting services, a recognition of the cultural diversity in this region, that there should be this sort of very open approach to how often people might want to or need to access the safe space, so they should be able to visit as often as needed and stay as long as they need. Transport, as I said before, so the idea that the safe space itself would have transport available. And then in terms of what we're just calling broadly governance, so there was comment around the fact that it needs to be completely independent from existing LHD mental health services. So that recognition that a genuine alternative would also include this kind of real separation in terms of the organisational aspects of it and the governance aspects. So collaboration with other community groups, but remaining independent. So that recognition that this is a community-based service and that it is part of the community, and to try and get, I guess, existing resources that are already there. So recognising that if they could be harnessed, that would also help to support the safe space and what it does. And then oversight from people with lived experience who value co-design and non-medical intervention. So that's about peer workers in particular, really people that are committed to those values and principles, specifically have that kind of commitment as peer workers. Thanks, Tina. And then in terms of, we wanted to hear what people thought the safe space, what it should offer in terms of people's experiences of accessing and being supported in these spaces. And it was to be immediately greeted and be able to have a conversation right away. So that thing, I guess that speaks to the idea that people often, as we saw earlier, needing to wait or take time and to be assessed, but this idea that people are warmly greeted and able to talk to someone immediately, that there's practical and administrative support. So, but no time pressure for that paperwork. So recognising that the traditional system, there's a lot of burden on people to fill out a lot of paperwork. Information available about other services, about educational groups, eligibility is requested, but not presented in an overwhelming way. So that was also really spoke to the fact that those tools, those traditional tools in clinical services are often a barrier to building rapport, people were telling us, and also that people were already feeling overwhelmed because they were in crisis and didn't need that extra layer of things that they had to do, that they were required to do. Also, people were talking about that people would like to be supported to connect, to set goals if that's what people wish to do, and to do what they want in their own time, not as the staff want. So again, you can see this theme emerging about it's about what the person needs and wants, and for them to determine that for themselves. Peer support groups attached. So there was conversations around could there be groups within the safe space or sort of associated with it that could provide ongoing peer support. Therapy animals on site. So dogs they often come up in co-design processes for safe spaces. So dog, and even more ambitiously a pony. A drop-in community area offering day programs. Carers and loved ones are able to present with and support someone. So there was a lot of conversation around that, like what is the purpose of the safe space in terms of support for carers, recognising that the natural supports of people who experience suicidal crisis are a very important piece of the puzzle in their recovery potentially. And so what can the safe space offer those people, those natural supports? Also, there was emphasis on the fact that it's while that is important to recognise and to be able to sort of meet those people's needs, it isn't, some people felt that it wasn't a space for carers to obtain direct support from themselves, but more able to connect to a different arm of support, or to be warmly connected to other services if they're available, or even someone suggested to provide a phone-in line for carers, specifically for carers. There was also someone thought that coaching to build skills and coping strategies. So some people thought that part of the remit of the safe space would be that it would provide this sort of capacity building around people's ability to sort of self-manage. And then also links to other relevant services in the region, including on-demand connection to medical and health support, if that's what people identify as needing, and ability to connect a consumer with their preferred mode of support. Also a safe and non-patronising, sort of non-monitoring environment. So really moving away from that sort of traditional risk assessment and management approach that's taken in emergency departments with people that are in distress. specific groups for men was identified as a need, and we do know that men die by suicide at much greater rates than women. So there was recognition of that, and or if there wasn't a specific group for men, then linking with existing community groups to meet those needs, and also able to provide non-clinical assessments by asking the right questions and seeking information. Thanks, Tina. And then staffing. So in recognition that the Ministry of Health requires that safe spaces are staffed by what they call SP peer workers. So they're peer workers with their own lived experience of suicidal crisis and recovery, who are specially trained to provide suicide prevention services within safe spaces and other services. So in terms of the local co-design participants with lived experience here, they said that they wanted to see key workers to establish continuity of care, not asking consumers to tell their stories multiple times to multiple different staff members, that there should be diversity within the staff in terms of culture, gender and sexual orientation. The workers themselves have their own diverse range of lived experience. So recognising that lived experience is a broad church, and so not just lived experience of crisis, but attempt, also some talk around whether people with a lived experience of caring, for example, would also be of benefit in the safe space. There was also an emphasis on the need for background checks for all workers, including disclosure of their own significant lived experience. I think that came from someone who said that they in traditional mental health services that these background checks are not always done. That was one person's comment. Gendered spaces that allow the consumer to choose who they would like to work with. So just again, that idea that people can have choice where possible in terms of how they're supported and who supports them. And that workers who are knowledgeable about medication was someone's comment, and workers that have the ability to make referrals and work on a forward plan with the person in a collaborative way. Also the opportunity for, as I said, so diverse lived experiences. So opportunity for a family or carer peer worker, clear processes and boundaries for peer workers, including clarification around the risks and legalities of peer work. So that was that idea that someone made the comment that it's important that peer workers themselves have an understanding of what the scope and nature of their own practice is, and that peer workers are available that can provide practical information, advocate and walk alongside in a coaching capacity, walk alongside people in their recovery. Thanks, Tina. So that you can see, I hope you can see now what Tina and I experienced facilitating this. It was a wonderful process to see what incredibly rich contributions people with lived experience in this region have made. The depth of insight that they bring to those experiences is really quite remarkable, and we both felt very fortunate to be facilitating this process. So now we will give an opportunity to anyone that's watching this live. If you have any burning questions, please put them in the Q&A function. If it's no problem if no one does now, you're quite welcome to feed those questions back either to Roses directly or in the survey. If you go to that survey, click that link, which will be on the landing page of your LHD on the Roses website. That's your opportunity to provide further feedback, to answer. There's a series of questions there. There's also a space just to make general comments. So if there's anything, if you're a direct co-design participant that you feel that you want to make further comment, please complete that survey. For other community members, this is where you get your opportunity to have your own voice heard as well. We also really encourage people to spread the word in their local communities. We know that people with lived experience often have great informal networks, and we really encourage you all to share this link around. We want to hear from as many people as possible. We know that by doing that, you are more likely to get a local safe space that meet the needs and wants of all community members. So I don't see any questions coming up now, and I'm just mindful of the time. So perhaps we'll just briefly go through next steps before we wrap up, Tina, and we'll just keep an eye on the Q&A. So this is feedback loop 1. We've just completed the webinar, and as I said, the survey questions. We will then have another session with the health professionals where they'll be provided with all the lived experience outputs so they can provide us with further input around that. We'll have another feedback loop that follows this same process, and then we finally have what we call the joint stakeholders session. So the big combined sessions where really we start getting very, very concrete about things like location, the connection pathways, those sort of things, so that the co-design service model it really shapes up there a final feedback loop to really communicate the outputs from the co-design process, and then your LHD will receive from Beacon Strategies a final report that that outlines the service specifications that have been generated through this process. So there's no questions now. So yeah, again, I just want to say thank you so much for just the enormous contributions that people with lived experience have made so far to this process. I know will continue to make. Tina, I don't know if you have anything that you'd like to add there. Or...
No, I think you said it very well, Carrie. It was great to be involved in this process with the people of Wagga. So thank you.
Yeah, we really do deeply appreciate it, and we'll see you all soon. Thank you.